So the topic for today is about thyroid and anti-thyroid agents. In this regard, we are going to lecture the pharmacological agents that can be used to correct problems in thyroid hormone levels. So since ang i-discuss natin are those modifiers of thyroid hormones, it is important for us to know what are these thyroid hormones, ano yung mga possible ways of the body to regulate the level of the thyroid hormones, and more importantly, the process of production. Okay, so that's why I've decided to have this topic outline to facilitate ladderized learning. Number one, we will review the organ called thyroid gland because it is the specialized region or area of the body that produces the thyroid hormones. And then after that, the regulation of thyroid hormone synthesis and release, and that is under thyroid pituitary relationships. After that, we will discuss the biosynthesis of thyroid hormones. Ibig sabihin, sa third part, i-discuss natin paano ba na-produce ng thyroid cells ang mga thyroid hormones. And after which, we will proceed in discussing different types of thyroid hormones and then clinical conditions related to thyroid hormones, be it deficiency or excess. And finally, drugs that would correct those problems. So first stop, let's have a brief recall regarding the thyroid gland. The butterfly-shaped thyroid gland is located just inferior to the larynx. So that's why you can see on the figure, we have here the larynx, and then beneath it or inferior to it, we have the thyroid gland. So ito yung thyroid gland, para siyang letter H as you can see. It is composed of right and left lateral lobes. So these are the left and also the right lateral lobes. And then the one that connects them, okay, the one that connects them is called the isthmus. Okay, that is called the isthmus. Isthmus is said to be anterior to the trachea. Now, microscopic analysis of the thyroid gland, makikita natin ang mga cells or makikita natin ang specific components. These are called the thyroid follicles. Okay, these are called the thyroid follicles. Now, thyroid follicles are composed of thyroid follicular cells. Okay, these are composed of thyroid follicular cells. At ang thyroid follicular cells ay nasa walls ng follicle. Okay, nasa walls or nasa border ng thyroid follicle. And inside, ay inside or sa gitna, we have the internal space. Ang tawag naman natin sa internal space ay lumen. Ay tawag doon ay lumen or colloid. Again, that is called colloid or lumen. So I repeat, makikita natin microscopic analysis in the thyroid gland. We have thyroid follicle, and thyroid follicle is composed of the follicular cells that are found in the border or in the walls, and inside we have the space called colloid or lumen. Very important ang mga parts na to, particularly in the synthesis of thyroid hormones later. Okay? So that is the thyroid gland. Now, ang thyroid gland, this is where the different thyroid hormones are being produced. Like for instance, the T3, and also the hormone T4. So later, madidiscuss pa natin in details ang T3 and also T4. But for now, take note, sa thyroid gland siya napoproduce. Now, ano ang specific regulator ng thyroid hormone production? So ano yung specific trigger para ma-induce ang synthesis and also release of this T3 and T4? Of course, may controller tayo sa katawan, and that is called the axis between the hypothalamus, the anterior pituitary gland, okay, the anterior pituitary gland, and also the peripheral organ called the thyroid gland, of course. So ang tawag dito ay axis, okay, axis of hypothalamus, pituitary, and thyroid gland. Thyroid-pituitary relationship. Bakit natin siya tinawag na axis? Kasi ito ay domino effect. Okay, domino effect, ibig sabihin, cascade of events siya para eventually mag-produce or mag-synthesize ng thyroid hormones ang thyroid gland and ultimately ma-induce ang release and distribution. So paano siya nag-i-start? In the brain, we have again, in the brain, we have the region called hypothalamus. Ang hypothalamus ang initiator ng axis in which hypothalamus secretes a specific hormone that is called TRH. Again, that is called the TRH. TRH stands for thyrotropin releasing hormone. Okay, again, ang tawag dito ay thyrotropin releasing hormone. In general class, whenever you hear, ito ay applicable na sa iba pang lesson sa endocrine na less likely na may encounter natin. Usually kapag ang hormone ay releasing hormone, ang origin niya ay hypothalamus. Okay? Ang origin niya ay hypothalamus or hypothalamic hormone siya. Now, what happens next? Once secreted, the TRH or thyrotropin releasing hormone will bind to the receptor found in the anterior pituitary gland. Anterior ibig sabihin sa harap na pituitary gland. And binding to the receptor causes synthesis and release of another hormone called thyroid stimulating hormone. So TSH stands for thyroid stimulating, again, thyroid stimulating hormone. So TSH stands for thyroid stimulating hormone. FYI, thyroid stimulating hormone is also known as thyrotropin. Okay, this is also known as thyrotropin. That's why you can double check sa hypothalamic hormone the TRH earlier is the one responsible that would release TSH or thyrotropin from the anterior pituitary gland. Okay? Next, so continue natin. After secretion of TSH from the anterior pituitary gland, this TSH eventually will arrive in the thyroid gland. Take note, in the thyroid follicular cells, we have specialized receptors for TSH. So pagdating ng TSH dito sa thyroid gland, merong receptor na makikita sa thyroid gland where TSH binds. And that is simply called as TSH receptors. Again, these receptors found in the thyroid gland are called the TSH receptors or the thyrotropin receptors. Note, class, that these receptors accept TSH as ligands. So binding of TSH to the receptor would cause synthesis of CAMP. Okay, this would cause synthesis of CAMP because ang receptor is coupled, G protein coupled receptor or GPCR kasi siya. Okay, G protein coupled receptor. So moving on, kapag na-produce or na-synthesize ang CAMP, this would trigger production of T3 and also T4. Okay, this would produce T3 and also T4 in the thyroid gland. So yan ang axis from the hypothalamus to the thyroid gland. So with this information being discussed, what must be inferred? Ano yung dapat nating ma-realize? Number one, take note, makinig. Number one, hindi spontaneous ang production ng thyroid hormone by the thyroid gland. What I mean to say is, hindi porket trip ng thyroid gland gumawa ng thyroid hormones, gagawin niya. Hindi siya ganon. Dapat may mag-stimulate ng production. And the stimulator of the production is the TSH. Question, bakit ba na-secrete ang TSH from the anterior pituitary? Kasi ang master gland natin, the hypothalamus, secreted formerly TRH. Okay? That's why cascade siya or domino effect. So for instance, if your hypothalamus is defective, if hypothalamus does not work well, for instance, it doesn't secrete TRH, eventually, the thyroid gland would be affected. Kasi walang ilalabas na TSH ang anterior pituitary, it won't secrete TSH. Kasi wala nang galing na TRH eh. And that's why walang thyroid na or walang thyroid hormones na mapoproduce. Okay? Naintindihan niyo yung sinasabi ko? So, cascade of events siya. Okay? Cascade. Hey, do you understand? Okay. So, burahin natin ha. Let's add something. So, for example, continue natin. you can see on the figure that may nakalagay na negative feedback mechanism or negative feedback. What do we mean by this? Suppose that there is increased production of thyroid hormones T3 and T4 by the thyroid gland. Kapag masyado ng marami ang dinistribute sa different parts of the body, eventually, this T3 and T4 would also reach the hypothalamus and anterior pituitary gland. Take note, pag umabot sa point na mare-receive ng hypothalamus at anterior pituitary gland ang T3 and T4, pag excess na siya, that would induce negative feedback. Pag sinabi nating negative feedback, ma-oppose ang stimulation na naganap earlier. That is, through negative feedback mechanism, through distribution of excess T3 and T4 to the master glands, mapipigilan nila ang further secretion ng TRH and TSH, which would eventually prevent the thyroid gland, from producing excess T3 and T4. That's why ang axis of hypothalamic, pituitary, and thyroid is an example of a negative feedback mechanism. Okay? So something that is excess, like T3 and T4, would eventually prevent the master glands from secreting the hormones that they produce. So that's why we have inhibition of TRH and also TSH from these master glands. So that is for the thyroid-pituitary relationship. So let's continue. Since diniscuss natin that the regulator of thyroid, focus tayo sa thyroid gland ha, sa thyroid gland. Since the regulator of production is the TSH binding to the receptors, suppose na nag-bind siya, kaya magkakaroon ng formation ng T3 and T4. Now, the question is, paano siya nagaganap? Paano nangyayari ang production ng T3 at T4? Yun ang susunod nating i-discuss. So number one, in the biosynthesis of thyroid hormones, nangyayari ito sa thyroid follicular cells. Again, the site of production is in the thyroid follicular cells. So sila lang ang specialized cells that synthesize thyroid hormones like T3 and T4. Note that no other cells can produce thyroid hormones. Sila lang. Okay? Na-discuss natin kanina kung saan located ang thyroid follicular cells. Di ba nabanggit natin ang thyroid follicular cells ay makikita sa borders or sa walls. So dito siya. So kapag minagnify natin ang site na ito, halimbawa, in this area, kaya kapag minagnify natin ito, it appears like this. Okay? Magiging ganito yung itsura. So first stop, i-familiarize muna natin ang bawat part para hindi kayo malito. On the left portion, I repeat, on the left portion, blood, okay, sa dugo. And then, yung color violet na box na nakikita nyo, yung color lavender na nakikita nyo, ito yung follicular cell, okay, follicular cell. And then, sa leftmost portion, ito na yung space inside. Okay, space inside. Anong tawag natin sa space inside? It's letter L. Ano yung letter L? It's called the lumen. Okay, lumen. Lumen is also called as, anong another term sa lumen? Anong another term sa lumen? Okay, so that is also known as colloid. So lumen is also known as colloid. So at least you are now familiar with the areas na i-discuss natin. Okay, so first stop, let's have in the blood. In the blood, we have freely circulating ions like sodium ions and also iodide. Okay, iodide. Ang iodide ay importanteng ion sa ating katawan and isang klaseng cell lang ang kayang mag-uptake ng iodide. Wala nang iba pa. And the one that can cause uptake of iodide is the follicular cell. And remember that iodide is an important raw material for the production of thyroid hormones. Kaya nga we deem follicular cells as the specific cells that produce the thyroid hormones. Okay? Anong clinical correlation nun? Anong clinical correlation? Ganito, sa buong parte ng katawan, dapat ang iodide ay madedetect nyo sa thyroid gland lang. Pag may nakita kayong iodide, for example, sa utak o sa iba pang parts ng katawan, ibig sabihin, may naligaw na thyroid follicular cell doon. Okay? Nagets yung ibig ko sabihin? May naligaw. Halimbawa, nung in-MRI ang utak mo, may nakitang iodide doon. So that implies na may follicular cell ng thyroid sa utak mo. O anong sakit related doon? Cancer. Nag-metastasize na yung thyroid cancer mo. Naintindihan? Kumalat na siya. Okay? So yun yung determinant natin. Kung sakaling merong metastasis ng cancer cell involving thyroid cells. So anyway, going back, so paano papasok sa follicular cell ang iodide? Okay, paano siya papasok? So ang iodide will undergo the process called active uptake process. Again, the first step is what you call as active uptake process. And in active uptake process, that means ang iodide together with sodium ions will enter into the follicular cell. And that is made possible by the symporter called sodium iodide symporter. Okay? So that is via the sodium iodide symporter. So you can see now that the iodide and sodium ions are found in the follicular cell. So hindi na natin papansinin yung sodium ion dito. We will focus more on the iodide. Okay? We will focus more on the iodide. So next, number 2. The next step involved is transport of iodide from the follicular cell going to the lumen or colloid. So biyabiyahe ang iodide from the follicular cell papunta sa colloid via a transporter called pendrine. So second step is the iodide transport, through the process or through the assistance of the transporter pendrine. Hence, at the end of step 2, you can see that ang iodide ay nasa lumen na or nasa colloid. Next, number 3. Okay, number 3, bago natin i-discuss ang fate ng iodide in the lumen, let's tackle first a specialized protein that is found in the follicular cell. So ang tawag natin sa specialized protein na yon is thyroglobulin. Ang thyroglobulin is synthesized in the follicular cell as well. And on the third step, it causes exocytosis. It facilitates exocytosis of thyroglobulin from the follicular cell. Okay, so there is exocytosis of thyroglobulin. That's why you can see that after synthesis of thyroglobulin from the nucleus and eventually packaging, tendency na e-exocytose na siya, kaya you can see thyroglobulin sa lumen or in the colloid. So far at the end of the step 3, we can find iodide and also the protein thyroglobulin in the lumen or colloid. Nasusundan? So active uptake and then iodide transport via pendrine and then exocytosis of thyroglobulin. Can you follow? No one's answering. Nakikinig ba kayo sa akin? Okay. So burahin ko na. Next, step 4. Okay, step 4 tayo. Remember, recall tayo ha, sa steps 1 to 3. Ang end ng step 3, makikita natin ang thyroglobulin sa lumen and also yung iodide sa lumen as well. So ang step 4, this is mediated by the enzyme peroxidase. So step 4, we have the peroxidase, peroxidase catalyzed reactions. Again, on step 4, we have peroxidase catalyzed reactions or peroxidase catalyzed steps. So there are 3 steps involved or 3 processes involved under this number. we have peroxidase catalyzed reactions. So pag sinabi natin peroxidase catalyzed reaction, yung tatlong steps na isusulat ko, lahat ito ay dahil sa peroxidase enzyme. So number one, we have oxidation of iodide into an atomic iodine. Okay, into an atomic iodine. Ibig sabihin, from having a charge of -1, naging 0 na ang charge niya. Okay, uncharged na siya, bale. So that is for the first reaction held by peroxidase. That's why makikita nyo sa lumen, sa illustration natin, you can see in the lumen portion that ang iodide through oxidation, naging atomic iodine na lang siya. Okay, naging iodine, which has a charge of 0. Next, ano pa yung ibang steps under peroxidase catalyzed reaction? So aside from peroxidation of iodide into elemental or atomic iodine, we also have organification of iodine. Okay, also we have organification of iodine. What do we mean, class, by organification of iodine? I repeat, ang i-discuss na natin right now, organification of iodine. So pag sinabi nating organification of iodine in Tagalog, again in Tagalog, ang iodine na atomic, yung iodine na atomic ay didikit sa thyroglobulin na nilabas kanina. Okay, again, ang mangyayari sa organification, yung iodine na atomic ay idadagdag sa thyroglobulin. Now, paano siya dumadagdag? Again, paano siya dumadagdag? Para magets kung paano siya dumadagdag, i-discuss natin briefly what's with this thyroglobulin. Again, discuss natin what's with this thyroglobulin. Tandaan natin na sa thyroglobulin, ito ay specialized protein. Okay, protein siya in the follicular cell na nakakarating sa lumen, and this thyroglobulin consists of tyrosyl residues. So meron siyang mga tyrosyl residues. So when we say tyrosyl residues, makikita nyo sa structure ng thyroglobulin na may mga tyrosine na amino acid. Okay? Ang tyrosine, ito ay may side chain na phenol. Di ba? Meron siyang side chain na phenol. Kaya makikita nyo sa ating structure ng thyroglobulin, we have side chains here, phenol. Yan yung mga tyrosyl residues. So ang mangyayari, balik tayo sa organification na, sabi ko, idadagdag ang iodine sa thyroglobulin. That is ang mangyayari, ang iodine ay didikit sa tyrosyl residue. Okay? Didikit siya sa tyrosyl residue. Kaya makikita nyo dito, may mga dumikit na color violet sa drawing natin after iodination or after organification. Okay? So yan ang organification. Nadadagdagan ng iodine yung tyrosyl residue. So focus tayo ngayon sa organification pa rin, particularly the products. Again, particularly the products of organification. So meron tayong dalawang possible products ng organification. Pag sinabi natin products, ito yung posibleng magagawa pag dumikit ang iodine. May dalawa tayong product kasi depende sa dami ng iodine. Again, depende sa dami ng iodine ang dumidikit sa tyrosyl residue. Halimbawa, may product tayo na nagagawa kasi isa lang ang iodine na dumidikit sa tyrosyl residue. So ang tawag doon ay mono tyrosyl residue. Okay, again, ang tawag doon ay monoiodo tyrosyl residue. Pag sinabi nating monoiodo tyrosyl residue, ang dami ng iodine na dumikit sa tyrosyl, isa lang. Okay? Isa lang ang dumikit. Next, paano naman kapag dalawa? So somehow, common sense, kapag dalawa naman na iodine or atomic iodine ang dumikit sa tyrosyl residue, ang tawag doon ay diiodo. okay, diiodo-tyrosyl residue. I repeat, for the products of organification, pwedeng dalawa. Number one, we have monoiodo-tyrosyl residue. Isang iodine lang ang dumikit. And then kapag diiodo, dalawang iodine. So that is organification. So far, na-discuss na natin ang dalawang processes held by peroxidases. First is oxidation of iodide, and second, organification of iodine. How many reactions are involved in peroxidase catalase reactions? Ilan? Ilan? 3. Okay, very good. Tatlo. So meron pa tayong isang natitira. Okay, meron pa tayong isang natitira. And that is called coupling reaction. Okay, again, ang tawag doon ay coupling reaction. Ang coupling reaction ay tinatawag ding conjugation. Okay, again, ang tawag doon ay conjugation. That's why dito sa ating illustration, may mababasa kayong conjugation. So question, paano siya nangyayari at ano ang product na magagawa? Take note class, o conjugation tayo. Take note that in conjugation process, ang tendency or coupling process, yung products ng organification, the products of organification are conjugated with one another, magkokopol sila sa isa't isa, magdidikit sila sa isa't isa. Okay? So with that, ano yung mga possible reactions under conjugation? Number one, may instances na isang monoiodo-tyrosyl residue ay isang pirasong monoiodo-tyrosyl residue ay magko-conjugate o magkokopol, didikit siya sa isang diiodo-tyrosyl residue. Okay? So again, pwedeng isang monoiodo-tyrosyl residue ay magkopol o dumikit sa isang diiodo-tyrosyl residue. Pangalawang pwedeng mangyari sa coupling reaction, yung products ng organification, particularly, isang diiodo-tyrosyl residue at isa pang diiodo-tyrosyl residue ang magkopol sa isa't isa. So again, dalawang coupling reactions ang pwede mangyari. Una, isang mono, isang di. Pangalawa, isang di at isa pang diiodo-tyrosyl. So i-add natin. O, tanong ko ulit sa inyo, ilan ang iodine content ng MIT or MIT? Ilan ang iodine content niya? Isa o dalawa? Isa, very good. Ang diiodo, ilang iodine content? Dalawa. 1 plus 2, ilan? Okay, very good. 3. Kaya pag nag-couple ang MIT at DIP, that causes formation of T3. Okay? Di ba? Hormone ba ang T3? Thyroid hormone ba ang T3? Yes, okay. Kaya lang ang problema dito, class, ito ay nakakopol pa sa thyroglobulin. Nakadikit pa siya sa thyroglobulin na yung na protein na pinagdikitan ng iodine kanina. Okay? Next, after coupling reaction, sa second process, pag isang di at isa pang di ang sumama, ilang iodine content na ang meron? 4. Very good. Kaya meron tayong T4 thyroglobulin. So at the end, makinig, at the end of conjugation process which is found here, we have the products T3 bound to thyroglobulin and then T4 bound still to thyroglobulin. So these are the peroxidase catalase reactions. Question, saan nangyayari ang peroxidase catalase reaction? Sa follicular cell o sa colloid? Very good, in the colloid. So we have steps like oxidation of iodide, second, organification of iodine, and lastly, coupling reaction. Pwede na tayo mag-continue? Buburahin ko na ha. Next. So number 5 na tayo, 5th step. So after natin sa peroxidase catalase reaction, number 5 is proteolysis. Okay, number 5 is proteolysis. lysis or proteolytic reaction. Not to mention that, bago ko makalimutan, not to mention that the conjugated T3 and T4 to thyroglobulin will be endocytosed. Papasok ulit sa thyroid follicular cell. Kaya mangyayari ang proteolysis sa loob ng follicular cell ulit. So iikot siya. Papasok siya ulit sa thyroid follicular cells. And ang proteolysis ay mangyayari because of lysosome. Okay? So because of lysosome na merong lysozymes. So when we say proteolysis, there is cleavage of protein component from the thyroglobulin and also thyroid hormone. So it appears like this. Remember, ano nga ulit ang products ng coupling reaction? Ano ang products ng coupling reaction? T3 na bound sa thyroglobulin and then T4 na bound sa thyroglobulin. Now, in proteolysis or cleavage of protein component, it simply means that the thyroglobulin will be detached, will be removed from T3 and T4 na complex. So that's why ang product natin ng proteolysis, again, the product natin ng proteolysis, we have free T3 and free TG, and then T4 and free TG. Magkahiwalay na sila. Okay? Nahiwalay sila. Wherein, ang free thyroglobulin will be ready for reuse. Gagamitin siya ulit for another round of synthesis. And then, we already have the free T3 and T4. So taken all together, the process of or the reason or the essence of proteolysis is to separate T3 and T4 from the protein. And pag nangyari yon, ready nang ilabas ang T3 and T4 as independent hormones. Naintindihan yung proteolysis? Naintindihan ang proteolysis? Okay, so that's good. So done on step 5. Next, step 6. O sige, recall muna tayo ng mga steps. Recall muna tayo ng mga steps bago natin makalimutan. Number 1, ano ang tawag sa may sodium iodide symporter? Anong process yon? Active uptake. Okay, active uptake. Next, after ng active uptake, kailangan ba makarating ng iodide sa lumen or colloid? Yes or no? Yes, okay, very good. What about the thyroglobulin? Kailangan din ba makarating siya sa colloid? Yes. Okay? So after nun, meron tayong peroxidase catalyzed reactions. Na-discuss natin siya kanina. We have oxidation of iodide, organification of iodine, and then coupling reaction. And after that, proteolytic cleavage. So after natin sa proteolytic cleavage, we can see that meron na tayong free T3 and T4. So ang T3 ay tinatawag ding triiodothyronine. Okay, again, ang T3, it is also known as triiodothyronine. Kaya may makikita kayo sa figure na triiodothyronine. And then, thyroxine naman for T4. Okay, thyroxine naman for T4. So on step 6, again, on step 6, we have release process. Step 6, we have release of T3 and T4. So this causes release of T3 and T4 that is via the MCT or the monocarboxylate transporter. Okay, so that is via the monocarboxylate transporter. Now, in the release process, it is important to know the ratio of release between T3 and T4. In Tagalog, kailangan nating malaman kung gaano karaming parts ba ng T3 ang nilalabas at gaano karaming parts ng T4. Take note, ang ratio ng T3-T4 release ay 1:5. Okay, again, the ratio of release is 1:5. Ibig sabihin, one part lang ng T3 ang nilalabas at 5 parts ang nilalabas for T4. Kaya we eventually understand that majority ng thyroid hormones na nanggagaling sa follicular cell, T4. Okay, T4. So that is for the release. Next, number 7. Can we proceed on the step 7? On step 7? Okay, after release, we can expect that ang thyroid hormones T3 and T4 ay nasa dugo na. Thus, it can reach or they can reach their target peripheral cells. However, along their way or during circulation of these hormones, there is peripheral event that happens. Okay? There is peripheral event that happens. And pag sinabi nating peripheral event, habang pinapamigay na siya sa katawan. Okay? Habang pinapamigay na siya sa katawan. So ano yung nangyayari during peripheral event? So that is deiodination, okay? Deiodination of T4 to T3. Okay, again, along their way, habang pinapamigay sa iba't ibang parts ng katawan, ang T4 ay pwedeng ma-convert into T3. And that is via the enzyme deiodinase. Okay, that is via the enzyme deiodinase. What do we mean by deiodination? So ulitin natin, habang dinidistribute sa different parts of the body, pwede siyang ma-deiodinate. That is, yung dami, makinig, yung dami ng thyroid or yung dami ng iodine, dami ng iodine na meron ang T4 na babawasan. So that is, from having 4 iodine, nagiging 3 na lang yung iodine niya. Kaya deiodination. Kaya eventually, ang T4 ay nagiging T3 din bago siya makarating ng peripheral organs. Bago makapasok sa peripheral organs, facilitating their effects. Okay? So that is the peripheral event. Kaya makikita nyo, maiko-connect natin siya sa release process. So it makes really the balance. Remember, pag na-release ang T3 and T4, at first, mas maraming T4, di ba? Pero eventually, habang pinapamigay nga siya, ang T4 ay nagiging T3. Well, in fact, 80% ng T3 sa ating dugo ay galing sa T4. Okay? In fact, 80% ng T3 na nasa blood natin, hindi siya originally galing sa follicular cells. Siya ay derived lang din sa T4. Naintindihan niyo yung sinabi ko sa deiodination? Ha? Okay. Huwag niyong kakalimutan niya na meron siyang implication. And also later, i-discuss natin yung difference ng T3 and T4 in terms of their activity. Okay? In terms of their activity. So that's the end of biosynthesis. Okay? Tapos na tayo sa biosynthesis. So recap lang tayo, we have 7 steps. Number 1 is active uptake. Second is transport of iodide. Third is exocytosis of thyroglobulin. And in the lumen, we have 3 catalytic reactions by peroxidase. Number 1 is peroxidation or oxidation of iodide. Number 2 is iodination or organification of iodine, wherein iodine is being added to tyrosyl residues na makikita sa thyroglobulin. Now, ang product pwedeng mono, pwedeng di. And that product or those products will couple with one another, forming either T3 and T4 that are bound to thyroglobulin. That's why proteolytic cleavage is important para mahiwalay ang protein component. So after proteolysis, ang T3 and T4 would be secreted finally and then distributed. And in the distribution, as I've said, eventually ang T4 ay magiging T3 via deiodinase enzyme. So that's the end of biosynthesis. Naintindihan overall ang biosynthesis? Okay, so that's good. Actually, this figure is similar to what I presented a while ago. Pero ang i-emphasize ko na lang dito, class, yung T4 nga, T4 we have thyroxine or tetraiodothyronine. So another term dito is tetraiodothyronine because there are 4. There are 4 iodine molecules found. Whereas ang triiodothyronine, we have T3. Okay, T3. You can actually see in the structure of T4 na meron tayong 1, 2, 3, and 4. Okay, 4 na iodine molecules na makikita, and they are bound to the tyrosyl side chain. Di ba makikita nyo na nasa phenol siya dumikit. Kaya nga, organification is important. Next, in T3 naman, we have 1, 2, and then 3 iodine that can be seen. And as I've said, they are bound to the tyrosyl residue that is in the side chain of phenol. Okay, so yan ang structure ng T4 and also T3. This figure is only a supplement to what I discussed a while ago. Same lang siya ng mga processes na diniscuss natin kanina. Okay? Now, let us discuss the different thyroid hormones produced by the thyroid gland. So we focus on T3 and T4. As I've said, ang T3 is triiodothyronine having 3 iodine, and then thyroxine naman, we have 4 iodine. These hormones are important because they normalize the growth and development, body temperature, and energy levels. In addition, thyroid hormones like T3 and T4 are very important for metabolism. Okay? So important sila for metabolism. And as you can see, ang triiodothyronine has lesser iodine content as compared to T4, having 65%. Kasi nga, makikita natin sa structure na numerous ang iodine or greater ang iodine compared sa T3. Okay, so that is for triiodo and thyroxine. With respect to the activity of these hormones, what is the difference? Tandaan, ang T3 is 10 times more active. Again, T3 is 10 times more active than T4. So again, T3 is 10 times more active than T4. Meaning to say, the physiological effects of T3 is so much greater than thyroxine. Okay? Kaya eventually, kung ang thyroxine ay mako-convert into T3, there is enhanced thyroid-mediated effects, lalo na pag nakarating sa mga target tissues. So these are T3 and T4. And in terms of release, na-discuss ko na kanina ang range of release. Sino ang mas maraming sinesecrete by the follicular cells initially? Is it 4 or 3? 4. What's the ratio? 1:5. 5 parts for T4. Okay? 5 parts for T4. So that's good. However, or sorry, not however, in addition to T3 and T4, we have another hormone that is produced by the thyroid gland, and that is calcitonin. Ang calcitonin ay naka-include sa discussion on bone homeostasis, and makikita yun sa lesson 7 ng Canvas yun. Okay? So this is second type of thyroid hormone and important for calcium metabolism. So we will focus only on T3 and T4 right now. This table summarizes the effects brought about by thyroid hormones. Parehas lang na epekto ang T3 at T4 in terms of the target organs. But yung extent of activity greater than T3. So number 1, we have calorigenesis. So in calorigenesis, there is increased oxygen consumption and oxygen dissociation, increased basal metabolic rate, and increased temperature. Okay, so that is the first effect, metabolic. And in the lipid, there is enhanced hepatic LDL receptor synthesis. Remember, we discussed hepatic LDL receptors in dyslipidemia. These are receptors that would cause endocytosis of LDL. Okay, so this would cause endocytosis of LDL into the hepatocytes or liver cells. Again, endocytosis of LDL into the hepatic cells. Such endocytosis would lower blood cholesterol. Kaya, ang thyroid hormone is a regulator of cholesterol. And also, carbohydrate, there is increased absorption of carbohydrate from the GI tract. Okay, so that is the effect, metabolically speaking. So we have calorigenesis, lipid effect, and carbohydrate. Important ang mga metabolic effects na to kasi maiko-correlate natin siya sa mga simptomas ng diseases affecting thyroid hormones. Also, we have cardiovascular effect. Note that thyroid hormones are inotropic because they can activate beta receptors. So that's why they can enhance force of contraction and also increasing rate and enhanced cardiac output. Renal effect is fluid retention. Neurological, importance sa nervous system development, ay importance sa nervous system development, and also essential for growth. That's why, if naabutan nyo, inadvocate before ng DOH ang pagkain ng mga meals containing or using iodized salt, with the use of iodized salt. Ang iodized salt, as the term suggests, iodine containing siya. Ang iodine ay importante sa thyroid hormone production. So ang point kung bakit ina-advocate yon ng DOH para magkaroon ng enough iodine supply yung isang tao. And di ba ang iodine, ang fate lang naman niya para maging thyroid hormones. And with that, mapopromote ang growth and neurological development sa mga bata. So yan yung reason kung bakit ina-advocate yon ng DOH. Kasi na-i-induce ang formation ng thyroid hormones. Next, this table summarizes the typical values for thyroid function tests. So I'm not requiring you to memorize the values because sa clinical pharmacy nyo gagamitin ang mga values na to. And sa actual practice naman, you can always check the values in the app or in the internet. Kaya actually, hindi na kailangan na i-memorize literally yung mga values. Pero in case na stat or biglaan or mabilisan yung mga results, syempre, skill pa rin na alam nyo siya or memorize nyo siya. But sa subject ko, no need for you to memorize. I'm just showing to you the typical values of the thyroid function test. This will serve as the evidence kung ang patient ba ay may normal thyroid hormone o kaya merong abnormal thyroid hormone. Question, kapag abnormal, anong mga clinical conditions ang pwedeng mai-associate? So pag abnormal ang thyroid hormone levels, dalawa lang ang pwedeng kahinatnan. Abnormally low or abnormally high. Pag abnormally deficit, ang condition is generally called hypothyroidism. Okay, hypothyroidism. And if abnormally higher than the normal value, that is hyperthyroidism. Hence, we will discuss next the different clinical conditions. So paano kapag sobrang baba than the normal ng thyroid hormone? So una, ang tawag doon ay thyroid hormone deficiency. Okay, thyroid hormone deficiency or simply called as hypothyroidism. Okay, hypothyroidism. Meron tayong iba't ibang possible causes ng hypothyroidism. Number one is iodine deficiency. So ito somehow maiintindihan nyo easily kasi diniscuss natin ang biosynthesis. You understood earlier that iodine is an important raw material for T3 and T4 production. Thus, if there is deficiency of iodine, affected ang production ng thyroid hormone. Right? And this is often observed. Iodine deficiency is often observed in developing countries like the Philippines. Yung mga mahihirap na bansa, common ito. Kaya nga, nabanggit ko kanina, ina-advocate ang iodized salt use para magkaroon ng easy source ng iodine sa tao, lalo na sa bata. Okay? Next, another cause of thyroid hormone deficiency is post-procedural. Okay, post-procedural. Ang post-procedural naman ay common sa mga developed countries. So sa developed countries, yung mga mayayamang bansa. And when we say post-procedural, it means merong procedure na kinandak o ginawa sa patient. And because of that procedure, bumaba ang thyroid hormone. Ano yung mga examples natin ng post-procedural cause? Number one, syempre, pag nag-undergo ang patient ng thyroidectomy, okay? Pag nag-undergo siya ng thyroidectomy or surgical removal of thyroid hormones. Siyempre, pag wala ka ng thyroid hormones, wala ka ng follicular cells. So, pag wala kang follicular cells, walang gagawa ng thyroid hormones. Okay? So, post-procedural yan. And then, after that, use of radioactive iodine. Okay? Use of radioactive iodine. Okay? Use of radioactive iodine. Ang radioactive iodine kasi ay isang radioisotope that destroys thyroid gland or thyroid cells. So sinusunog niya ang thyroid cells. So pag nasunog, wala nang gagawa, syempre. Okay? And aside from that, thyroiditis. Another possible cause is thyroiditis. Okay? Thyroiditis. So these are the example conditions post-procedural kapag ang patient ay merong hypothyroidism. Next, pwede rin namang autoimmune. Okay, pwede rin namang autoimmune. Like for instance, Hashimoto's disease. Okay, Hashimoto's disease. Okay, Hashimoto's disease. And then we have drug-induced. So there are agents that can cause hypothyroidism. Like for instance, amiodarone. Okay, as we discussed before. Okay, for instance, we have amiodarone. And this is because of the Wolff-Chaikoff effect. Okay, that is because of the Wolff-Chaikoff effect caused by amiodarone. Na-discuss natin before sa arrhythmia ang Wolff-Chaikoff effect due to local control. Okay? So drug-induced, we have use of amiodarone, particularly because of the Wolff-Chaikoff effect. So everybody, these are the causes, possible causes of hypothyroidism. Number one, we have iodine deficiency. Next, post-procedural like thyroidectomy, use of radioactive iodine. And also we have conditions like thyroiditis, autoimmune like Hashimoto's, and drug-induced using amiodarone. Okay? So yan ang mga causes. Next, dun tayo sa figure sa baba. Okay, dito tayo sa figure sa baba. Yung figure naman sa baba, this describes the types of hypothyroidism. So meron tayong iba't ibang types ng hypothyroidism. We have primary, secondary, and tertiary hypothyroidism. So sa hypothyroidism types, ang pinaka-common ay primary, ay the most common type of hypothyroidism is the primary, followed by secondary, and the rarest o yung pinakamadalang ay tertiary hypothyroidism. So, anong pinagkaiba ng tatlong types na ito? Okay? Maiko-connect natin ang mga types ng hypothyroidism sa axis na diniscuss ko earlier, sa axis. Again, hopefully nandyan pa kayo, maiko-connect natin ang types ng hypothyroidism sa axis, sa hypothalamic pituitary thyroid gland axis. Remember ang axis natin o yung regulation of release, first we have hypothalamus, second is the anterior pituitary, and then third, we have the thyroid gland. Okay, and then we have the thyroid gland. Question, ano nga ulit ang sinesekret ng hypothalamus na hormone? Is it the stimulating or the releasing hormone? Okay, very good, releasing. So that is the thyrotropin releasing hormone. And then, secretion of TRH would cause production and release of TSH by the anterior pituitary. And ultimately, the thyroid gland will secrete T3 and T4. Okay? Ultimately, mapoproduce and mare-release ang T3 and T4. So yan yung axis. May kinalaman dito ang types ng hypothyroidism. Number one, pag primary ang hypothyroidism, ang problema o ang sirang organ ang thyroid gland. Kaya ito ay thyroid gland defect. Okay, again, number one, for primary, okay, that is thyroid gland defect. Pag secondary naman, ang defective organ ay ang pituitary gland or anterior pituitary defect naman kapag secondary hypothyroidism. And finally, pag tertiary hypothyroidism, hypothalamic defect siya. Okay, again, kapag tertiary, this is said to be hypothalamic defect. So I repeat, primary is thyroid gland defect, secondary anterior pituitary defect, and lastly for tertiary hypothalamic. Now, anong ibig sabihin natin ng mga defects na yan? Ibig sabihin, ang problemang organ ang hindi nakikipag-cooperate sa axis, yung mga organs na sinabi ko. At pag sinabi nating hindi nakikipag-cooperate, yung hormone na supposedly i-release nila, hindi nila nare-release na maayos, mababa sa ating blood. Okay, mababa sa ating blood. So number 1, sa primary, paano mo malalaman na may thyroid defect yung isang tao? Paano mo malalaman na ang defective sa kanya thyroid gland? Itetest mo ang levels ng TSH at ng T3 at ng T4. Okay, itetest mo sa blood. Di ba may diagnostic test tayo? Yung nasa table kanina ng mga values. So yan yung gagawin nating reference. So malalaman natin pag primary defect kapag ang TSH at T3, T4 iba or distinct yung mga values. So number 1, okay, number 1, kapag ang thyroid gland ang defective, anong ine-expect nyo sa level ng T3 at T4? Mataas o mababa? Okay, very good. Kapag thyroid gland defect, expected natin na ang T3 at T4 mababa. Kasi nga, yung gland, yung follicular cell, hindi siya makagawa at hindi siya makapaglabas ng T3 at T4 kaya mababa. Now, ang TSH naman, kumusta ang TSH? Ang TSH ay normal ang level, normal, or in some cases, mataas ang levels ng TSH. Again, kapag primary defect, mataas o kaya normal ang value ng TSH. So pag tines ang thyroid function mo at ganito ang values na nakita, possibly ang condition mo ay primary hypothyroidism. Okay, primary. Question, bakit ang TSH dapat mataas o kaya normal? Ulitin ko, related siya sa axis. Okay, related siya sa axis. Importante ba ang TSH para gumawa ng T3 at T4 ang thyroid gland? Importante ba ang TSH? Important ba yung TSH para sumunod ang thyroid gland in producing T3 and T4? Yes. So ang point dito is, ang hypothalamus at pituitary gland, normal. Okay sila. Okay sila mag-function. They normally release TRH, they normally release TSH. Kaya lang, ang thyroid gland hindi nga nakikipag-cooperate. Kaya kahit pumupunta ang TSH sa thyroid gland, it cannot bind to the receptor. Pag hindi nag-bind sa receptor, no synthesis and release of T3 and T4, kaya mataas ang TSH pero mababa ang thyroid hormones. Naintindihan yung ibig kong sabihin sa levels na normal tapos mababa? Naintindihan to? Okay, very good. O next, since nasakyan nyo yung primary defect, dito tayo sa secondary defect. So sa secondary, hypothyroidism naman, anong parte ng axis ang sira, ang problemado? That is the anterior pituitary gland. Okay, anterior. So sa anterior, normal ang hypothalamus, normal ang thyroid gland. Okay? Anterior ang may sakit o may problema. That's why makikita nyo din sa diagnostic test, sa resulta ng diagnostic test, kung secondary ba siya, ay kung secondary hypothyroidism. So based on your understanding, can you tell me what would be the level of TSH, T4, and T3 during secondary? Sa TSH, is it high or low? Very good. It should be low. It should be low kasi defective yung naglalabas ng TSH. Question, pag mababa ang TSH, susunod ba ang thyroid gland? Yes, kasi sinong boss ng thyroid gland? Ang TSH, di ba? Ang regulator ng release ng T4 at T3, TSH. So pag walang nilabas na TSH, hindi gagawa ang thyroid gland kahit normal siya. Nakita nyo ang difference ng primary at secondary hypothyroidism in terms of diagnosis? Ha? Okay. So yan ang pinagkaiba. TSH ang determinant. But anyway, ultimately, T3 and T4 ang affected. And then pag tertiary, ito sobrang rare. So kung sakaling may suspect siya na hypothalamic ang defect ng hypothyroidism niya, sasamang imo-monitor ang TRH. So pag lahat mababa, obviously pag lahat mababa, hypothalamic defect na siya. So mababa ang TRH, mababa ang TSH, mababa ang T3, mababa ang T4. Okay, so that is for tertiary hypothyroidism. So overall, yan ang different types. Again, these are the different types of hypothyroidism. Ano ang pinaka-common na type ng hypothyroidism? That is the primary. Okay, primary. Nagets ba ang causes and types of hypothyroidism? Pwede na tayo sa next slide. Okay, since na-discuss na natin ang mga causes and also types of hypothyroidism, dito tayo sa mga symptoms. Symptoms. Usually, in hypothyroidism, since there is deficiency of the hormones, yung mga effects na pinakita natin earlier like this ay kabaliktaran. So that's why patients with hypothyroidism have slow metabolism. They have slow metabolism. In addition, patients with hypothyroidism are cold intolerant. In Tagalog ng cold intolerant, ang bilis lamigin. Lamigin sila, okay? Kung may kakilala kayong may hypothyroidism, pansin nyo, mabilis silang lamigin. Kaya kahit kainit-init, naka-jacket sila. Okay, naka-jacket. Next, increase sleeping time. Antukin sila. Okay, antukin. There is also slowness in movement. Ang bagal-bagal nila gumalaw. And then, mahina na nga kumain, pero ang bilis pa nilang tumaba. Ito yung mga tao na kahit diet ng diet, mataba pa rin sila kasi nga mabagal ang metabolism. Remember, one of the effects of thyroid hormone is to enhance absorption of carbohydrates and also calorigenesis. So since kulang ka ng thyroid hormone, talagang magwe-weight gain ka kahit mabagal ka or kahit mahina ka kumain. Okay? And worse, there could be myxedema coma. Okay, myxedema coma. In myxedema coma, this is an example of hypothyroidism emergency. Okay, hypothyroidism emergency because this could be fatal. Okay, this could be fatal because of extreme fatigue, constipation, cold intolerance, and weight gain. So this could potentially be fatal to the patient. Okay, so yan ang mga symptoms ng hypothyroidism. Now, in case that a patient has hypothyroidism, ang problem usually ay mababa ang thyroid hormones, lalong-lalo na yung T3 and T4. So basic lang ang ating management, you add what is lacking. You supplement what is lacking. Kaya usually ang gamot na binibigay natin sa mga taong may hypothyroidism, mga replenishing agents lang. So ang tawag doon ay mga synthetic thyroid hormones. Okay? Synthetic thyroid hormones. So yung mga synthetic thyroid hormones, we have the following examples. Number one is dextrothyroxine, dextroisomer siya, and then levothyroxine, levoisomer naman siya. So when we compare dextro from levo, mas active or mas potent ang levothyroxine. Okay, mas potent siya. That's why ang clinically useful nowadays ay ang levothyroxine. Okay? Siguro may kakilala kayo nagte-take ng levothyroxine. Ang example brand niya is L-troxine. Okay, yan yun. Okay? Preparation of choice for thyroid replacement and suppression therapy. And for liothyronine, okay, liothyronine, this is a specific type of levothyroxine that is 3 to 4 times more potent than levothyroxine. Okay? So ito yung mga synthetic thyroid hormones na ginagamit natin most of the time. Lalong-lalo na yung levothyroxine. So yan lang ang gamot na ginagamit pag kulang ka ng thyroid. So mas magfo-focus tayo in terms of drugs kapag sobra kasi mas marami tayong drugs available. So let's proceed to hyperthyroidism. Basically, pag sinabi nating hyperthyroidism, there is thyroid hormone excess. Ay sobra ka naman ng thyroid hormone. So that's why in hyperthyroidism, we often call it as thyrotoxicosis because tissues are already exposed to high levels of thyroid hormones, and diagnostically speaking, there is increased T3 and T4 levels despite of having low TSH levels. Okay? Again, there is increase in hyperthyroidism, there is increased T3 and T4 levels, and then low TSH. Question, bakit ganito ang diagnostic values kapag may hyperthyroidism ka? Related ba ang axis dito kanina? Yes, very good. Related yung axis dyan kanina na diniscuss natin. Class, anong sabi ko kanina sa axis? Balikan natin yung slide na to. Nabanggit natin earlier na kapag may excess T3 and T4, darating ang time that this excess T3 and T4 will go to the hypothalamus and anterior pituitary gland. And once detected by these master glands, there is negative feedback. This means to say that the master glands will inhibit release of the hormones. So normally, pag inisip mo na na-block through negative feedback ang release ng TSH, dapat susunod ang thyroid gland, wag na dapat siyang mag-secrete. Okay? Nagigets ba ako? Normally, dapat ganon. Kaya lang in hyperthyroidism nga, nagsosolo ang thyroid gland. That is, kahit sabihin ni bossing na pituitary gland na, uy, tama na, wag ka na maglabas. That is, dapat bumaba na ang TSH from the pituitary gland. Ang thyroid gland nagsosolo pa rin. Bahala ka, basta ako maglalabas. Kaya ang defective usually dito, yung thyroid gland itself. Okay? Masyado siyang hyper in the production of T3 and T4. Naintindihan ba't ganito ang condition sa hyperthyroidism? Yung values ng thyroid hormones. Okay, so good. So pag hyperthyroidism, mababa ang TSH, mataas ang T3 and T4. So with that being said, ang salarin natin ay ang thyroid gland mismo, yung follicular cells. We discussed earlier that in the follicular cells, ang dami-daming steps na nangyayari. Kaya kapag gusto natin targetin ang synthesis of thyroid hormones, ito ang pupuntahan natin mamaya. Okay? So anyway, dun muna tayo sa condition. So this is characterized by increased T3 and T4 levels, but TSH decreases. So the most common, again, the most common cause of hyperthyroidism is Graves' disease. So ano muna yung Graves' disease para maintindihan nyo bakit nagsosolo ang thyroid gland sa paggawa ng thyroid hormones. Ang Graves' disease ay isang autoimmune disease. Okay? This is an example of an autoimmune disease wherein the defective lymphocytes, they produce antibody that activates TSH. In other words, nagpo-produce ang defective lymphocytes ng TSH antibody. Now, ano ang ginagawa ng TSH antibody na to? Ang TSH antibody, this activates the TSH receptors in the thyroid gland. Okay, again, ang function ng TSH antibody ay ina-activate niya ang TSH receptors that are found in the thyroid gland. Question, everybody, critical ba ang activation ng TSH para gumawa ng T3 at T4? Is it important na ma-activate ang TSH receptors para ma-form ang T3 and T4 in the thyroid gland? Yes or no? Okay, very good. So kapag na-activate ang TSH receptors in the thyroid gland, it is expected na tumataas ang T3 and T4. So related siya sa diniscuss ko kanina. Kasi kahit mababa ang TSH from the anterior pituitary, may ibang compound that is yung TSH antibody, siya yung nag-activate ng TSH receptors. Kaya nagsasarili ang thyroid gland. Kaya nagsasarili siyang gumawa ng T3 and T4. So the most common is Graves' disease. So during Graves' disease, focus tayo everyone sa Graves' disease. So sa Graves' disease, meron tayong triad of effects. So usually, ang patient na may Graves' disease, may mga ganitong simptomas. So number one, as I've said, there is hyperthyroidism. Kaya nga, di ba, yung mga taong may Graves' disease, tumataas ang thyroid hormones sa katawan. Kaya isa siyang cause. Aside from that, yung mga taong may Graves din, meron silang ophthalmopathy. Ophthalmopathy. So anong meaning ng ophthalmopathy? Ang ophthalmopathy, ito ay epekto ng Graves affecting the eyes, ay yung mata. Wherein, parang luluwa yung mata nila. Pansin nyo sa mga taong may hyperthyroidism or may Graves disease, yung kahit normal yung mata nila, para silang dilat na yung iris nila kitang-kitang buo. Di ba normally ang iris natin, dapat ang iris part lang ang kita. Parang ganyan normally. Pero sa taong merong ophthalmopathy, lumuluwa na halos ang mata nila. Okay? You can search sa Google kung ano itsura ng mga taong may ophthalmopathy. Next, we also have dermopathy as one of the triads of Graves' disease. Okay? Dermopathy. So this is characterized by lesions and redness in the skin. Okay? Redness and lesions in the skin. So this is the triad of Graves. That's why isa sa causes ng hyperthyroidism yung Graves. Next, aside from that, hyperthyroidism may also be caused by solitary hyperfunctioning nodules and also drug-induced. So ang drug-induced, ganun pa rin, this can be caused by amiodarone pa rin. Okay, amiodarone. Kasi nga, saan tayo nag-stop? Wait lang. Ayan, okay. So again, sa drug-induced, we have amiodarone as the cause. Because we discussed previously that amiodarone, nakikita nyo na ba ulit? Nag-exit siya, nag-crash siya. So amiodarone is an agent that can cause Wolff-Chaikoff. So because of Wolff-Chaikoff, initially may hypothyroidism and then eventually pag tumagal, may hyperthyroidism. Okay? So drug-induced. Next, nakopya nyo ba kanina yung triad? Nabura siya, sorry. Nakopya nyo ba? Nakopya nyo? Okay, so very good. Ulitin ko, ang triad hyperthyroidism, ophthalmopathy, dermopathy. Next, signs and symptoms. For the signs and symptoms of hyperthyroidism, these are the following. Number one, in general, there is hypermetabolic and hypersympathetic states. So take note that there is excess thyroid hormones. So kung excess ang thyroid hormones, we expect na sumusobra ang metabolism ng tao at enhance ang cardiovascular and other related effects. That's why, number one, heat intolerance. Yung mga taong may hyperthyroidism, kahit nakatodo na yung aircon, sobrang naiinitan pa rin sila because of excessive effect of thyroid hormones, which is heat generation. Okay? Kaya mainitin sila. Next, nervyoso sila. Kung may kakilala kayo merong thyroid problem, hyperthyroidism, mabilis silang nervous, nanginginig sila agad. At because of cardiovascular effect, there is tachycardia. So, mabilis ang tibok ng puso. And also palpitations. Yun nga, tremors, nanginginig. And then what else? Pawisin sila, pawisin. And then, ang takaw-takaw nila. Sila yung mga taong sobrang lakas kumain pero hindi sila tumataba. Okay? Apakalakas kumain pero bakit ang payat-payat nila? So, there could be a thyroid problem in them. Kaya sa inyo, kung feeling nyo sobrang lakas yun ng kumain pero ang payat nyo, you can have an assessment sa thyroid levels or thyroid function nyo. Okay? What else? Increased irritability. Ito yung mga taong yung may kaibigan ako dati nung college na meron siyang hyperthyroidism. Grabe. Parang araw-araw may problema siya sa buhay kasi parang gaganon siya agad. O bakit ba? Parang gano'n, irritable siya lagi. Kasi effect yun ng hormone. Okay, effect yun ng hormone. And then, eye changes, ophthalmopathy. Nabanggit natin na lumuluwa halos yung mata wherein buong iris na ng mata ang nakikita sa patient. Okay? That is hyperthyroidism. Next, so proceed naman tayo sa clinical management in patients with hyperthyroidism. So bago tayo morning health break, let us first introduce the therapeutic management. Remember, in hyperthyroidism, ang problema ay ang thyroid gland, okay? The one that synthesizes the thyroid hormones. That's why Ang paraan natin usually, we have three. Number one, use of anti-thyroid agents. Use of anti-thyroid agents, ibig sabihin, these are the medications that would alter the biosynthesis na diniscuss natin kanina. For instance, yung mga gamot na nagtatarget ng active uptake, yung mga gamot na nagtatarget ng organification, ng peripheral conversion, and so on. Okay? Also, pwede rin ang thyroidectomy. So, surgical removal of the thyroid gland. However, the risk of having this is hypothyroidism. Okay? So, ang risk dito is hypothyroidism. Kaya yung mga tao na nag-undergo nga ng thyroidectomy, they are being given supplement or supplementation of thyroid hormones, synthetic thyroid hormones. And then finally, destruction of the gland using radioactive iodine. So that is, pwede rin mag-cause ng hypothyroidism yun. Okay? Usually, ginagawa ang radioactive iodine therapy kapag, halimbawa, pag worse na yung situation or in some cases, may continuous production ng thyroid cells which could be cancerous. Okay? Which could be cancerous. So these are the treatments that can be done para ma-manage ang hyperthyroidism. So we will focus more on anti-thyroid therapy kasi dito related ang drugs, and magkakaroon tayo ng konting discussion on radioactive iodine later. Okay? So far, ang na-discuss natin ay yung clinical conditions, biosynthesis, also, what else? Diagnostic tests. Ano pa yung mga na-discuss natin? I think yun na-discuss natin so far. Okay? And then the axis, by the way. So after the break, 5-minute break, we will start discussing anti-thyroid agents. We have 5 examples of anti-thyroid agents. So let's have a health break first. Naintindihan ba yung lesson? Okay, sige. Their goal is to lower excessive production of thyroid hormones brought about by defective thyroid gland. So we have 5 groups na i-discuss. Number 1 are the thioamides, followed by anion inhibitors. Next, we have iodides. Next, we have radioactive iodine, and finally, beta blockers. So, i-discuss natin isa-isa yung mga agents na nakapresent. This figure summarizes the actions held by anti-thyroid agents. So, first stop, remember that the iodide from the blood circulation will enter through the active uptake process. So, merong inhibitor ng active uptake process, and these are the anion inhibitors. Okay, yan yung mga anion inhibitors. So somehow may idea na kayo, kapag na-block ang active uptake, syempre wala na tayong raw material na iodide, hence yung mga succeeding events sa formation ng T3 and T4, wala na din. Okay? What else? We also have thioamides. Thioamides are the ones that can block the action of the peroxidase enzyme. Particularly, ang binablock niya ay ang oxidation reaction of iodide into atomic iodine. Question, important ba ang oxidation of iodide para maging atomic iodine? Is this important? Yes, okay. Such inhibition will prevent organification. So that's why yung mga succeeding events din, wala na, okay? And also we have iodides and thioamides pa rin. They can also block this event. O anong tawag dito, class? Ay anong tawag dito? That is organification. Okay? They can block organification of iodine, organification of iodine with thyroglobulin. Next, we also have iodides pa rin. Okay? So pansin nyo, may mga multiple actions yung ibang anti-thyroid agents. These agents can block proteolytic cleavage. With that being said, we can infer that use of iodides will prevent separation of thyroglobulin from T3 and T4. So pag hindi nag-separate ang T3 at T4 from the protein itself, hindi siya pwedeng ilabas. So pag hindi na ilabas, edi wala sa blood, walang effect. Okay? So yan yung function ng iodides. And then finally, for radiocontrast media, beta blockers, amiodarone and thioamides, they can inhibit peripheral conversion of T4 to T3. Again, they can inhibit peripheral conversion of T4 to T3. Question, anong clinical impact ang maipoprovide ng ganitong action? Recall, class, when we discuss T3 and T4, we differentiated them in terms of their activity, right? Which between the two is more active, T3 or T4? Yes, T3. In fact, it's 10 times more active, right? And sabi natin, it's normal. It is said to be normal na bago makarating sa mismong tissues ang T3 at T4, ang T4 ay nagiging T3. Tandaan, pag ang patient ay may hyperthyroidism, hindi magandang mangyari to. Okay? Hindi magandang, wait lang, i-mute natin ha. Ayan. So hindi magandang mangyari ang peripheral conversion ng T4 to T3 kasi through this process, mas nai-intensify natin ang action ng thyroid hormones because of increasing number of T3. That's why by blocking the conversion, we tend to inhibit the conversion of less active T4 to more active T3. That's why pag gumamit ka ng mga agents listed, ano mangyayari sa level ng T3? Taas o baba? Baba, very good. And then, ang T4, yes, marami pa ring T4, pero if you come to think of it, this is lesser evil. Kasi mas marami ang less active kesa sa more active. Nagets nyo? Nagets ba? Okay. So discuss na natin isa-isa yung mga anti-thyroid agents beginning with thioamides. Examples of thioamides are methimazole and PTU. PTU stands for propylthiouracil. Okay, so this means propylthiouracil. So examples of thioamides are methimazole and also propylthiouracil. Now, meron tayong related agent to methimazole and that is carbimazole. Okay, that is carbimazole. Ang carbimazole is actually a prodrug of methimazole. Okay, this is actually a prodrug of methimazole. So these are the major drugs in the treatment of hyperthyroidism or thyrotoxicosis. Mechanisms of action, so we discussed this already. They prevent hormone synthesis by blocking iodide organification through inhibition of the peroxidase enzyme. Okay, by blocking iodide organification, so that includes both oxidation and iodination. And also, they can block coupling of iodotyronines. Okay, napipigilan ang pagdikit ng mga products ng iodination or organification. So regarding kinetics of thioamides, depende sa specific example. Halimbawa, for propylthiouracil, this is relatively safer in pregnant women as compared to methimazole and carbimazole. Okay? That's why ang PTU ang ginagamit for pregnant women. Okay, mas ginagamit siya for pregnant women. Ang problem kasi kay methimazole and carbimazole, they are teratogenic. Okay, they are teratogenic. That's why it's written here, can cross the placental barrier. At ang specific teratogenic effect ng carbimazole and methimazole is called aplasia cutis. Okay, that is called aplasia cutis. So again, the teratogenic effect caused by methimazole and carbimazole, that is aplasia cutis. Ang aplasia cutis is being observed in the epidermis of neonates. So ang problem sa aplasia cutis, yung epidermis wala at localized siya. So ibig sabihin may part ng katawan ng bata na walang balat, laman agad ang kita. Okay? Particularly sa scalp ito nakikita. So sa ulo ng bata makikita nyo, may mga segments doon, localized, na walang epidermis, muscle agad na makikita. So parang laman agad yung makikita. Okay? That is aplasia cutis. Less likely na mangyari ito using PTU, kaya PTU ay pwede sa buntis. Okay? Regarding propylthiouracil, it has faster onset of action but short duration, while for methimazole, it has lower onset but longer duration of action. And take note, methimazole is 10 times more potent than PTU, signifying that methimazole has lesser dose preparation available. Okay? It has lesser dose preparation available. So ano ba yung difference nila? Ang difference pa ng PTU at ng methimazole ay in terms of their usefulness. Usually for propylthiouracil, ginagamit ito during emergency cases caused by hyperthyroidism, okay? Emergency cases. Whereas ang methimazole, ito ay, since may longer duration siya, ito ay ginagamit for long-term therapy or maintenance use. Okay? For maintenance use. So yan yung mga differences ng methimazole and propylthiouracil, which are both thioamides. So okay na tayo sa first group, which are thioamides. Next are the anion inhibitors. As I've said, anion inhibitors can block active uptake of iodide by inhibiting the sodium iodide symporter. So ang anion inhibitors ay rarely used na due to aplastic anemia effect. Okay? So aplastic anemia. So ang aplastic anemia, again, aplastic anemia is a fatal adverse effect affecting the blood because all blood components, they decrease, bumababa, such as red blood cells, white blood cells, and also platelets. Kaya because of aplastic anemia, use of anion inhibitors is being discouraged already. Okay? Next, after natin sa anion inhibitors, so for anion inhibitors, by the way, ang examples dito hindi natin nalagay, pero ang example ay pertechnetate. Pertechnetate. And then we have thiocyanate. So example, we have pertechnetate and thiocyanate. Next, iodides. Iodides are the major antithyroids being used before introduction of thioamides. So examples of iodide preparations are Lugol solution. So yung strong iodine solution na ginawa nyo ba ito sa dosage form before? Ginawa nyo ba siya? Okay, so ginawa nyo siya siguro sa dosage form, or if hindi, na-encounter nyo sa dosage form. Di ba it contains iodine, strong iodine solution siya. So meaning, pwede siya mag-provide ng iodine supply sa patient. And also we have potassium iodide and iodine. Now, anong rasyonale ba't ginagamit natin ang mga iodides? Although meron siyang provision ng iodine. That is because ang iodide, yung preparation ng iodide, they inhibit organification process. So pag sinabi natin organification, yung addition of iodine to thyroglobulin, okay, thyroglobulin molecule or thyroglobulin proteins. And then they can also decrease the size and vascularity of enlarged thyroid gland. Okay? So yan ang action ng iodides. So bago na-discover ang thioamide, sila muna yung ginamit. Uses of iodides, number 1, for thyroid storm. Second, preoperative preparation for thyroid surgery. And protection of thyroid against fallout in the event of nuclear accident. Then, adverse effects. These are considered uncommon, but for your information, these are as follows. Number 1, we have acneiform rash. Second is rhinorrhea. We also have cases of conjunctivitis, bleeding tendencies, and in rare cases, we have anaphylactoid reactions. Also, we have polyarteritis nodosa, mucosal ulcers, and swollen salivary glands. Okay? Next, radioactive iodine. So, ang specific radioactive iodine na ginagamit natin for therapy is iodine-131. And iodine-131 is being used for thyrotoxicosis because it facilitates destruction of the thyroid gland. So, sisirain talaga niya yung follicular cells. Apparently, pag sira ang thyroid follicular cells, no biosynthesis. So, yun na yun. Okay? And for the effects, after oral administration, it is rapidly absorbed, and it focuses its effect in the thyroid gland lang. Okay? And destruction of the thyroid parenchymal cells occurred within 6 to 12 weeks. That's why ang possible risk dito ay hypothyroidism. Kaya patients that underwent radioactive iodine therapy are being given thyroxine, synthetic thyroxine after. So the following are the indications. So you can just read this out. Number one, patients above 21 years old which are not pregnant. Second, debilitated cardiac and elderly patients. Next, we have non-responsive to pharmacological agents indicated a while ago. And then, those patients na conflict na sa kanila yung mga prior drugs because of the toxicities. And finally, those uh, that suffer from symptoms even after a certain procedure was made sa kanilang thyroid gland. Okay, so that is radioactive iodine therapy. And for the last slide, we have use of beta blockers. Mind you that aside from blocking beta receptors, they can also inhibit peripheral conversion of T4 to T3. Na-discuss na ba natin everyone yung implikasyon pag binlock ang peripheral conversion? Were we able to discuss this earlier? Yes, na-discuss natin siya. Anong sabi natin? Lesser ang T3. Is it something good or bad pag lesser amount ang T3? Good. Okay, very good. Kasi nababawasan natin ang mas active form. That's why adjunctive agents sila for thyrotoxicosis. So na-discuss na natin ang ibang pharmacological actions ng beta blockers. Ang point ko lang dito is you have to remember that they can block peripheral conversion. Okay? So overall, these are the examples of anti-thyroid agents. So we have thioamides. Na-discuss natin ang propylthiouracil, ang methimazole, at ang prodrug na carbimazole, ang anion inhibitors, and meron palang examples dito, sorry, sinulat ko pa kanina. So we have perchlorate, pertechnetate, and thiocyanate. Iodides, we have Lugos solution and potassium iodide, radioactive iodine, and beta blockers. Ang summary lang ng MOA nila, lahat ito, okay, yung diniscuss natin dito. Now, bakit nyo siya madaling maiintindihan? Hopefully, bakit nyo siya madaling maiintindihan? Kasi yung mga diniscuss natin dito sa MOA related sa biosynthesis kanina. Okay? Kaya please invest sa biosynthesis portion. Once you understood this, madali na ang MOA ng gamot. So pag binlock ang organification, pag binlock ang proteolysis, peripheral conversion, you can actually imagine what's gonna happen. Okay? So overall, that's the end of our lecture for today.